Your baby was born, and in the delivery room, before you could even count their fingers and toes, a team of specialists surrounded them. Someone said the words bladder exstrophy. You saw something you didn't understand on your baby's lower abdomen. And in that moment, everything you imagined about your child's first hours of life was replaced by fear, confusion, and the crushing weight of a diagnosis you'd never even heard of. Stop. Take a breath. Because the next 24 hours will feel overwhelming. But what I'm about to give you is something most parents in your position don't receive until it's too late. A clear, honest, step-by-step guide to exactly what happens next, why it happens, and how to navigate the most critical day of your child's life. Bladder exstrophy is one of the rarest and most visually striking congenital conditions. It occurs in approximately 1 in every 50,000 live births. The bladder forms outside the body, exposed on the lower abdominal wall. The pelvic bones are separated. The urethra and external genitalia are affected. It looks frightening. It feels catastrophic. But here's the truth that will anchor you. It is surgically correctable, and your child can live a full, healthy life. Let me share a clinical scenario based on real medical experiences. We'll call this Mom Sarah. Sarah had a completely normal pregnancy. Every ultrasound was reassuring. No one suspected anything was wrong. But when her son Ethan was born, the room went quiet. The nurse took him to the warmer and called for the NICU team. Sarah's husband saw it first, a red, raw-looking mass on their baby's lower belly, below the umbilical cord. Urine was trickling from it. The pediatrician came and explained, bladder exstrophy. Their son's bladder was on the outside. Sarah said later that those first hours were the most terrifying of her life. But what made it harder was the silence. No one told her what the plan was. No one walked her through the 24-hour protocol. She was left in a postpartum room separated from her baby, frantically searching her phone for information that made sense. Today, I'm going to give you what Sarah needed. The first 24 hours, minute by minute, step by step. First, what exactly happened in the womb? During normal fetal development, the lower abdominal wall closes like a zipper. The bladder forms inside. The pelvic bones come together, and the muscles and skin cover everything. In bladder exstrophy, that closure fails in a specific region. The bladder forms, but because the abdominal wall never closed over it, it remains open and exposed. The inner lining of the bladder, the mucosa, is visible on the outside. Urine drains continuously from small openings where the ureters enter the bladder. The pelvic bones are widely separated, and in boys, the penis is short and split open along the top, a condition called epispadias. In girls, the clitoris is split and the urethra is open. The cause is not fully understood. It's not something you did. It's not inherited in any predictable way. It appears to result from a combination of genetic and environmental factors during very early embryonic development. Nothing you ate, drank, or did caused this. Now let me walk you through the first 24 hours. Because what happens in this window genuinely matters. Hour 0, the birth. As soon as the baby is delivered, the priority is protecting the exposed bladder. The bladder mucosa is delicate. It can be injured by friction from diapers, blankets, or even air drying. Immediately after birth, the medical team should cover the bladder with a non-adherent, moist dressing. The most common approach is to use saline-soaked gauze covered with plastic wrap or a specialized wound dressing to keep the tissue moist and protected. The umbilical cord should be tied, not clamped, to avoid injuring the bladder plate, which sits just below it. The baby is typically stable. Breathing is usually normal. The bladder exstrophy itself is not immediately life-threatening, but the baby will need to be transferred to a center with expertise in this condition. This is not a surgery performed at every children's hospital. You need a pediatric urologist who specializes in bladder exstrophy repair. Hour 2 to 4, the baby is transferred to the NICU. The dressing on the bladder is checked and kept moist. Pain is managed with age-appropriate medication. The baby is positioned on their back with the legs gently adducted, brought together, which can help bring the pelvic bones slightly closer. A pediatric urology team is consulted. The baby may undergo an initial ultrasound of the kidneys and spine to check for associated anomalies, which can occur in a minority of cases but are important to rule out. Hour 6 to 12. The pediatric urology team and the pediatric orthopedic surgeon will evaluate the baby. They will assess the size and quality of the bladder plate. They will check the separation of the pubic bones. They will discuss the surgical plan with you. This is where many parents face the first major decision: early complete repair or a staged approach. In early complete primary repair, the surgery is performed within the first 72 hours of life. The bladder is closed, the pelvic bones are brought together, sometimes with osteotomies, which are cuts in the pelvic bones to allow them to close, and the abdominal wall is reconstructed. This approach takes advantage of the fact that the newborn's tissues are pliable, and the pelvic bones can sometimes be closed without osteotomies if done very early. The baby may still need additional surgeries later, like bladder neck reconstruction or epispadias repair, but the major closure is done in one go. In the staged approach, the bladder is closed first, within the first few days. The pelvic bones may be brought together later, with osteotomies performed at a few months of age. Epispadias repair and bladder neck reconstruction are done in subsequent stages over the first few years of life. This approach is often chosen when the bladder plate is very small or the baby has other medical conditions that make a prolonged single surgery too risky. Both approaches have excellent long-term outcomes, and the decision should be made by an experienced exstrophy team based on your baby's specific anatomy. Hour 12 to 24, the surgical plan is finalized. Consent is obtained. The baby is kept NPO, nothing by mouth, in preparation for surgery. Intravenous fluids are started. The bladder dressing is maintained. And you, the parent, are in the hardest part, the waiting. Let me pause here, because if you're a parent in this situation right now, I need to say something directly to you. You may be feeling grief right now. Grief for the birth experience you thought you would have. Guilt that somehow this is your fault. Fear about what your child's life will look like. Anger that no one caught this before birth. All of these feelings are valid. All of them are normal, and none of them mean you're failing as a parent. Hold your baby if the medical team allows it. Talk to them. They know your voice. They know your heartbeat. The medical machines and the surgical plans don't change the fact that you are their parent, and your presence matters. Now, let me address the big question. What happens after the first 24 hours? What's the long-term picture? The surgery, whether early complete repair or staged closure, is the first major step. Recovery in the NICU typically lasts several weeks. The baby will have a catheter draining urine from the newly reconstructed bladder. The pelvic bones will need to heal, which sometimes requires the baby to be in traction or a special harness for several weeks. Pain is managed carefully, feeding resumes gradually. After discharge, your child will need ongoing follow-up with a multidisciplinary team: pediatric urology, nephrology, orthopedics, and sometimes gastroenterology and psychology. The goal over the first years of life is achieving urinary continence. Most children with bladder exstrophy will need a catheterization program, clean intermittent catheterization, to empty their bladder fully, as the reconstructed bladder often does not empty efficiently on its own. Some may require additional surgeries, such as bladder augmentation, to increase bladder capacity and achieve dryness. Now here's the part that every parent needs to hear. Long-term outcome studies show that with modern surgical techniques and consistent follow-up, the vast majority of children with bladder exstrophy achieve social continence, meaning they are dry during the day. Many are also dry at night, though some may need additional interventions. Kidney function is typically normal if the bladder is managed properly and urine does not back up into the kidneys. Fertility in girls is generally preserved, though pregnancies are high risk and require specialized care. In boys, fertility can be affected due to issues with sperm delivery, but reproductive options are advancing rapidly. But the most important outcome isn't measured on a kidney function test. It's quality of life, and research consistently shows that children with bladder exstrophy, when supported by informed parents and experienced medical teams, report quality of life comparable to their peers. They play sports. They go to school. They have friends. They have relationships. They become adults with dreams and careers and families. Let me give you your action plan for the first 24 hours. Write these down. Give them to your partner or support person. This is your roadmap. Step 1. Ensure the bladder is covered. Use saline-soaked gauze and a non-adherent wrap. Do not let it dry out. Do not apply pressure. Step 2. Advocate for transfer to a center of excellence. Bladder exstrophy repair is not a routine pediatric surgery. You want a hospital that has a dedicated exstrophy team and performs these surgeries regularly. It's okay to ask, how many bladder exstrophy repairs do you do each year? Step 3. Meet with the surgical team and ask the essential questions. Will you perform complete repair or staged? What are the osteotomy plans? What is the expected NICU stay? What does recovery look like for my baby? Step 4. Connect with support. Organizations like the Association for Bladder Exstrophy Community exist. There are parent-to-parent networks. You do not need to navigate this alone. There are families who have walked this exact path and are ready to guide you. Step 5. Give yourself grace. You will not absorb everything the medical team tells you. That's normal. Ask them to repeat it. Write it down. Record conversations with permission. You are in the middle of an emotional storm, and you deserve patience and clarity. Remember Sarah and Ethan? Ethan had early complete repair on his second day of life. His recovery was long but steady. He's now 9 years old. He catheterizes himself every few hours. He learned to do it independently by age 6. He's dry. He's in 3rd grade. He plays baseball. His mom, Sarah, now mentors other parents through a support network. She says the same thing to every parent. The first 24 hours are the scariest. But this diagnosis doesn't define your child. It's just one chapter. If this video gave you the information and the grounding you needed, hit like. It helps other parents find this guidance in the middle of their own first 24 hours. And if you're a bladder exstrophy parent or a patient living with this condition, share your story in the comments. What do you wish someone had told you in that first day? Your words could be the lifeline a terrified parent needs tonight. Next, watch the video on your screen. It explains the single kidney diagnosis and the 48-hour plan every parent needs. If your baby has multiple complex diagnoses, that video is your essential next step. You are already the parent your child needs. You are asking the right questions. You are seeking the right information. And you will get through this. 1 hour, 1 step, 1 day at a time.